Good evening, everyone, and welcome to tonight's webinar, National Cervical Screening Guidelines, a 225 update. We are joined tonight by speakers Dr. Lara Roeske and Professor Deborah Bateson. My name is Jovi, and I'm the Education and Events Officer for the Specific Interest Faculty at the RACGP. Just a few housekeeping notes to go over. So if you cannot see a panel like the image above, please place your cursor over the shared presentation screen and this panel will appear. This panel provides you with your audio options and most importantly, your Q&A box. We have placed everyone on mute to ensure learning will not be disrupted by background noise. So please chat to us using the Q&A box as the chat function has been disabled. We will do our best to address all your questions. However, in the interest of time, if you have any unanswered questions relating to tonight's session, I will share the email address at the end of the webinar. Just a couple more things. So tonight's webinar will be repeated on the 13th of March 2025. A recording will be made available after this date on the RACGP website webpage within the next week. And your CPD 1.5 hour of education activity will be uploaded within the next 7 days. And as well as automatically generated closed captions are available. Just note that Zoom may get a couple of words occasionally incorrect. And lastly, that's it. So I'd like to now formally introduce to you our GP facilitator and speaker for this webinar. Dr. Lara Roeske is a GP and previous practice owner, Provost of the RACGP Specific Interest, and has held many senior positions at the RACGP, including Chair of the RACGP Board, Chair of the RACGP Specific Interest, Deputy Chair of the Victoria Council, Inaugural Chair of the RACGP Specific Interest Sexual Health Medicine Group. Lara is a past member of the Australian Commission on Safety and Quality in Healthcare Cervical Screening Redrafting Working Group and Ministerial Advisory Committee on Bloodborne Viruses and Sexually Transmissible Infections, and past member of the Commonwealth Self-Collection Advisory and Implementation Committees and National Guidelines Working Party. Lara has worked in advisory roles to key stakeholders on steering committees representing the RACGP across a range of domains relevant to the sexual and reproductive health, cervical cancer prevention and translation of evidence into practice at state and national levels. So with that, I'd like to now hand over to Lara. Thank you, Lara.
Thank you. Thanks very much, Jovi. I'm really delighted to welcome so many of our members this evening and colleagues, and of course, a warm welcome to non-members who have joined us this evening. Thank you for your time and attention. It's now my pleasure to introduce my co-host, Professor Deborah Bateson. Deb is Professor of Practice in the Faculty of Medicine and Health at the University of Sydney. She's worked as a clinician, researcher, educator and advocate in sexual and reproductive health for over 20 years with a focus on equitable access to sexual and reproductive health care, including cervical screening. Deb is currently leading an NH and MRC study to increase cervical screening participation of people with intellectual disability. She's acting chair of the National Cervical Screening Program Clinical Advisory Group, former chair of the Self-Collection Implementation Committee, and was a member of the Cervical Screening Guidelines Update Working Party. So we're really fortunate to have you here with us, Deb, and to share your expertise. And for me, it's an absolute pleasure, as always, to work with you. We go back a long way. We're still here, which is great.
Thank you, Lara. That's lovely.
Fine. Most importantly, I would like to extend our acknowledgement, the traditional custodians of the land and the sea on which we work and live. I'd like to extend a very warm welcome and respect to our Aboriginal and Torres Strait Islander colleagues who have joined us this evening, and of course pay our respects to elders past, present and emerging. So without further ado, the learning outcomes for tonight's educational webinar are we will discuss, and you'll be able to discuss, the 2025 updates to the National Cervical Screening Guidelines in relation to general practice and specifically your practices. We will be, and we hope that you will, as a result of attending tonight, understand, outline and be able to implement changes to the guidelines across a number of important management protocols and pathways, notably for test of cure following treatment of high-grade squamous intraepithelial lesion as part of surveillance follow-up post-treatment of adenocarcinoma in situ, and also we'll understand the categories and expansion and clarification of immune deficiency for the various patients that present to us. We'll also use the updated guidelines, and we'll use case illustration to do this work, and Deb will be doing that for us this evening to really simplify management without, of course, compromising safety or quality for screening after total hysterectomy, and also for repeat HPV at 9 months or more in our patients who have a non-16-18 HPV detected on self-collection, however, do not turn up for follow-up LBC in a timely manner. And let's face it, that is an occurrence for us in practice, and we welcome hearing more about those changes. But I'm now going to hand over to you, Deb, and you're going to tell us some important information about the aims and the strategies of cervical cancer control in Australia. Over to you.
Thanks so much, Lara, and a pleasure to be collaborating with you as well. So good evening, everyone. Pleasure to be here. It is exciting news indeed that we can say Australia is predicted to eliminate cervical cancer by 2035. It may even be a bit earlier. In fact, we're the first country, we're going to be the first country in the world to do so. The key thing, though, of course, is we have to achieve this equitably. But how have we got to this enviable position? So it's through our HPV vaccination program. As you all know, it's a single dose now for gender neutral, so vaccinating girls and boys at age 12 and 13. Obviously, the other key thing was the change of the National Cervical Screening Program in 2017 at the end of that year from 2 yearly pap smears to HPV screening every 5 years. And then, of course, the landmark change of policy to universal access to self-collection. So everyone has that choice in 2022. Supported, of course, by the National Cancer Screening Register. It gives you that provider portal, which is wonderful. And so this enabled, it was the Assistant Minister for Health, Minister Jed Carney, to actually launch the national strategy for the elimination of cervical cancer in Australia. It was launched in November of 2023. And we're monitoring the progress against the targets that have been set. So I'll go to the next slide, please. Thank you. So what are our targets that we've set? So the WHO has set global targets by 2030, and we call them the 90-70-90 targets. So 90% vaccination, 70% around screening, and 90% around treatment. So we've got some stretch goals, I suppose you'd say. So just to remind us all that elimination is not eradication. So elimination, the threshold's been set at fewer than 4 new cases per 100,000 women. Our targets are 90% of all eligible people, so that includes boys as well as girls, to be vaccinated, 70% of people screened every 5 years who are eligible, and 95% of people eligible people will receive optimal treatment. And how are we going with these, reaching this elimination threshold? Well, at the moment, we're at 6.4 per 100,000. So overall, that's good, but we do know those inequities within populations. So for instance, Aboriginal and Torres Strait Islander women, 3 times higher rate of being diagnosed with cervical cancer, twice as high mortality. So we've really got to close these gaps. And we know that the priority populations are populations where there is under-screening. Aboriginal and Torres Strait Islander people, I've mentioned before, culturally and linguistically diverse people, the LGBTQ community, people with disability, and those living in rural and remote areas, as well as those with low socioeconomic background. Because what we know, so we've really got to focus our efforts here, because over 70% of invasive cancers are diagnosed in under and never screened people. Next slide, please, Jodie. But I want to tell you some good news as well. So this is looking at self-collection. It's looking at the count and the percentage of all HPV tests reported as self-collection. That's in yellow. The blue is the dark blue is clinician collected. And you can see, so if you look at the very start of the graph, it starts at the end of 2017 when the program switched to HPV testing. We didn't introduce self-collection, in fact, until early in 2018, but it was very restricted, if you remember, to start with. So it was only offered to underscreen people who are 30 and above, very small numbers, but that all changed when we introduced universal the universal choice. And you can see the numbers have been steadily going up since July of 2022. And now, in fact, I've just heard that it's actually up to 40% of all screening tests are now self-collected. And the really great news is that the greatest uptake is in amongst those who need it most. So it's in under and never screened people. It's also in older stage groups, which is interesting, very remote areas, in low socioeconomic groups, and amongst Aboriginal and Torres Strait Islander women. So this is good news indeed. So thank you. I'm going to hand on to the next slide and over to you, Lara.
Thanks very much, Deb. And before we actually go into and delve into the detail of the evidence-based changes and the new recommendations, and I think, Deb, we did have a really important little red star at the start to tell us this is all coming in April of this year. So those of you that are here tonight, it's a really good use of your time, because you'll be making these changes in a couple of months' time. It's a nice opportunity, however, to just pause and introduce our audience to the Magic App platform. Some of you will be familiar with it and some of you won't. I'll just pause and briefly tell you what it's all about. The link to the Magic App platform you'll see in a moment on the next slide, but we'll stay with this one. So what is it? It's an easy access digital platform that houses living evidence. It actually houses a very large number of evidence-based guidelines that are both national and international. And importantly, the cervical screening national guidelines are now found here and are housed here. Up the top right of the slide is, of course, the usual link. If you're looking for the guidelines, you can certainly find them via the Magic App platform, and we'll provide the link on the next slide, or via the Cancer Council Australia website, which some of you will be very familiar with and has been the usual way. Next slide, please. You'll also find a range of very useful resources for our GPs and practice nurses, and these are really designed to support and provide guidance to your clinical practice around cervical screening. That link's at the bottom of the slide, and we could, Jovi, maybe even pop it in the Q&A if that's possible, because people can have a quick look and familiarise themselves or keep it for reference. Our next slide is also an important piece of support that I think is really welcome for GPs again and practice nurses in the clinical setting. I think it's fantastic when those putting together guidelines really put something together specifically to provide us with guidance and advice and support in our clinical practice. And of course, that's where the known unknowns and the unknown unknowns and a variety of often a whole range of situations can challenge us. And what I found really useful, and I do commend this chapter to you, audience, and I do suggest if you're going to read anything, this is the one you take to bed and read at night diligently. We've got some very helpful sections here on explaining HPV to patients, the role of the National Cancer Screening Register, supporting informed choice is an example, but you'll see as you work through the chapter that the guidance is categorised to you around a range of scenarios, presentations and issues, really helping with actions that are either strong recommendations for, but really great to see strong recommendations against, also good practice statements and guidance, and consensus recommendations. And I think that provides a lot of comfort to clinicians who, again, often in day-to-day clinical practice have to deal with a whole range of issues that sometimes we feel perhaps guidelines don't sufficiently address or support us around. So a great chapter. Deb, it's over to you. Thanks.
Much, Lara. So this is just a summary of the changes, and I did just want to reiterate what Lara said, that the guidelines are just so much easier to use now. You can find the flow charts immediately. They're at the front of every chapter. Before, I do agree they were very difficult to find. So this is great. So the guidelines have shifted to this Magic App platform. It's incredibly easy to use and to navigate. And this new chapter, cervical screening in clinical practice, as Lara says, it's a one-stop shop. It's really your go-to and good bedtime reading, as you mentioned. The big changes we're going to cover today are the changes to the test of cure. And this is for people who've been successfully treated for a high-grade change and for AIS, and we'll go over exactly what those changes are. The other key thing, which Lara mentioned before, which is actually really fantastic when it comes to clinical practice, is a repeat HPV at 9 months if someone hasn't returned for their follow-up LBC. So in other words, they have a self-collected HPV test, it comes back not 16, 18. You know that you need to get them back. You advise them that ideally they come back within 6 weeks for that LBC, but life happens and people don't always come back. So if they arrive back at 9 months or later, maybe 12 months, for instance, then we know that, it's what we're doing then is just testing to see whether the HPV has disappeared or not. If it hasn't, if it's persistent, then you've got to obviously follow up on that with a cytology test. But if it's disappeared, they can go back to routine screening. Number 5, made just immune deficiency, it's much clearer, so we'll go through that. And also, hooray, screening after total hysterectomy has been simplified as well. So thank you, Jovi. We move on. Now, I know that, obviously all of you are so experienced and you all see all of these people in your clinic at some point or another, but it's just a reminder to us all really about just not missing these particular groups of people, because they're groups that may be under-screened, they may be missed sometimes. So, the people we should be encouraging, it's encouraging all people, of course, but it's encouraging people regardless of whether they're gay or lesbian, transgender or straight, whether they've had the HPV vaccination or not. We do know this is a common misconception that you don't need screening. And I will say that the group perhaps we're a little bit more concerned about at the moment because they're not coming for screening at rates that really they should be doing, which is the group who are aged 25 to 29. So I think that's just something to remember for us all. People who are no longer sexually active, very common to think I don't need screening anymore. They may not have been sexually active for years and think surely that's not needed. So you need to be able to correct misinformation. People who've been through menopause, people who've only had one sexual partner, again, maybe a long time ago, but still, that screening is needed because of that HPV transmissibility. People who've experienced traditional cutting or circumcision, have had a baby and are pregnant. So all the people that we see all the time. And I'll go to the next slide, please. So I think this is a useful slide because obviously we're talking about the guidelines and, at the center of that is the routine screening pathway. But there are just some groups where we just need to know they've got specific management advice. And again, was delighted to see when I just checked again today in the Magic App platform that it's really clear to be able to find these other groups. So, you don't have to go hunting around for information. It's all there. So we've just highlighted in orange here the ones that we're going to cover tonight because that's what's changed in the guidelines. So we've got, we've clarified around the management about the classification of who's included in immune deficiency. I'll talk to the management, the simplified management of after a total hysterectomy. We'll follow up. We'll give more information, of course, about the test of cure, both for a high-grade squamous lesion and after treatment for AIS. But just a quick reminder for us all. So someone's put in the chat, and it's an important thing, actually. So I think partly they're talking about, the equivalence in accuracy between self-collection and clinician collection, and we know that we've got that strong data there. The key thing here, though, is thinking about people with symptoms suggestive of cervical cancer. So we've always got to take that history. So there is, we do know it is easy sometimes to hand out a self-collected swab and perhaps forget to take that history, and you absolutely can't do that because, of course, if you're offering self-collection, you're not going to do an examination, and you do need to find out whether someone's got a history of post-coital bleeding, for instance, because if someone does have symptoms suggestive of cervical cancer, then you're not doing a screening test, you're doing a co-test. That's HPV and LBC on the same sample. It has to be clinician collected, and we do a co-test because it gives a lower threshold for referring to colposcopy. So always ask about symptoms. People who are pregnant. So we know pregnancy is an optimal time actually to offer cervical screening. It's often the time when people who haven't been in touch with a health service for ages and possibly never at all, that they're there coming in to see you for antenatal care, maybe turning up in a hospital. So we do want to be able to offer screening. It can be self-collected. It's very safe. If someone has changes that require colposcopy, we don't delay sending people to colposcopy. If they do, it's really to exclude serious disease. And usually, of course, treatment will be deferred till after the delivery. People who are aged 70 to 74. So I know, for myself, actually, I think I was a bit confused about this as well. And now I've been on the working group, I'm no longer confused. But the key thing about people who are 70 to 74 who come along for screening, basically the guidance here is that if they have any type of HPV detected, oncogenic HPV, so either 1618 but also non-1618, then they're referred directly for colposcopy. So if it's self-collected, they don't need to come back for that LBC test. And then if it's normal, then that's their last test. So if they're age 75 or above, it's the same sort of system, but basically we're just offering this to people who haven't had a screening test in the last 5 years, if they request that. Those exposed to DES, diethylstilbestro, they're getting fewer and fewer. They're probably, Lara, in their sort of 70s, I think, now. But these women, they do have that higher risk of various cancers, actually, including cervical and vaginal cancer. So they do have an annual co-test and actually annual referral for a specialized colposcopy, not just of the cervix, but also of the vagina. But their daughters, by the way, don't need any special testing. It's just routine screening. So I think, just be aware of who these specific groups are. And I'm going to go to the next slide, please. And it's over to you, Lara. You're on mute, I think. No, Lara, I think you're still on mute.
Oh my gosh. Thank you, Deb.
You told us a lot of interesting things.
What would I do without you? We've got 3 excellent questions. The middle one you'll be answering and in a really illustrative way around post-hysterectomy screening. But the first and the second, I'll just address now, and I know, Deb, you'll expand on those. It is really important at the outset, before we even go into the detail of guidelines changes, that the audience is completely reassured and confident in the huge current evidence base at level of meta-analysis, RCT, international, national, that supports the effectiveness, accuracy and safety of self-collection. So Biz, you don't need to be concerned, and busyness has nothing to do with accuracy. We are all busy. We're not actually opting to self-collect because we're busy. We're opting to self-collect because we are supported by the quality standards evidence base that's enshrined in our national screening guidelines. And behind that sits compelling evidence to support this as a safe, accurate option. Why I'm harping on this is, of course, our patients at times need to be reassured about the option of self-collection and why it is just as accurate as, and I use that wording with them, and essentially just as good as if the doctor takes the test. So I think we'll ask Deb to expand on that in the Q&A, but it's really important to state at the outset. Julie, very quickly, our job in practice is to actually individualise guidelines and advice. The NCSR performs a wonderful safety net function. The definition of what sexual activity means and constitutes in terms of transmission of HPV is sometimes difficult for patients and clinicians to understand. And Deb and I, you'll often hear us saying it involves all forms of sexual activity in terms of oral sex, anal sex, penetrative sex, and close genital skin-to-skin contact. And we start at 25 here. So understandably, patients and clients may be confused when they're invited, but it's not the NCSR's role to actually understand our patients in the way that we do, and I think we provide a really good complementary function in terms of actually further individualising a protocol or a guideline-based approach. Deb, do you have any thoughts there?
Yeah, look, I think you've explained that perfectly. I suppose the other thing that I would add on is just, just for us in clinical practice, is we know we might ask people whether they're sexually active. People often don't know what that means really. But the key thing is that we do, we can't make assumptions. And we do know that sometimes people will have experienced sexual assault or childhood sexual abuse, and they don't disclose that. And so we want them to be able to, it may take a long time for them to disclose it. We want them to really have a very low threshold for offering cervical screening. It's a very simple test, and you just want people to have that choice. We're not acting as sort of gatekeepers really, but I do agree that it is quite complex, that description, but I think hopefully we've answered your question over that.
Thank you, Deb. We've got a couple of other good ones. A lot of them pertain to hysterectomy, so I know you'll be assessing those and making sure you incorporate the answers during your session. And I think that last one we can talk to perhaps in the Q&A about how we actually do approach young people and what is a sensitive discussion around
and just the history, just the person aged 75 for a CST. As I mentioned before, but perhaps too briefly, yes, if someone comes and they're 75 or over, if they haven't had a screening test in the past 5 years, it will be covered, but ongoing screening wouldn't be covered, and it wouldn't be covered if they had a more recent screening test. So that's just good information there, but otherwise they would have to pay for it, and of course that's people's choice.
Deb, I'm going to be cheeky and say the average age of death of Australian women, I think, is upwards of 90.
Yes, good point.
So we all need to look at our superannuation and financial planning, I say. But we might have to think about what does good healthcare screening and prevention look like across a whole lot of illness and wellness.
Yes.
That's a discussion for someone else, but important point. Now, let's go to the test of cure, and this slide is the status quo currently. So just to refresh everyone's knowledge and update it, all people who've been treated for biopsy-proven high-grade squamous intraepithelial lesion are at an elevated risk of either disease recurrence or indeed progression, possible progression to invasive cancer. And that elevated risk is mooted to exist for around 10 to 25 years. So our job in the screening follow-up pathway is to have a protocol that's evidence-based to return people to baseline safely so that they can be returned to really the 5-yearly screening program. Currently, our protocol involves 2 co-tests performed annually and consecutively, a year apart. And of course, if both those co-tests are negative, those people can be safely returned to 5-year screening and are deemed to be at baseline risk. The change, which I think is welcome, is the next slide. Okay. So this slide is quite illustrative and easy to understand, and it tells us that really from April, the protocol has been simplified without compromise to quality and safety. And we can now offer and support 2 consecutive annual HPV tests, which can be collected through the self-collection method. So there is no need to insert a speculum necessarily and take a sample from the cervix for co-testing from April onwards, provided HPV is not detected. And I think our next slide illustrates that nicely. We actually have the algorithm, and if we follow the algorithm through, but I want you to cast your eyes on the caveat or the exception or the reason and the results that would underpin a referral for colposcopic evaluation in this pathway. So it's the bottom on my screen, right blue box. So if at any time during your follow-up annual consecutive HPV test, you return a 16-18 result on your patient, or you return a non-16-18 or a not 16-18, but the liquid-based, or a not 16-18, but LBC is high grade or glandular, or you return you return 3 consecutive HPV not 16-18 results post-treatment. So that would be in a sequence of 3 years annually, consecutively. Then you will need to organise a prompt referral for colposcopic evaluation and assessment. So I'm focusing on the result that we would most worry about, or the outcomes we would most worry about. And I generally say, quite loosely, your ears need to prick up in clinical practice if you're seeing 16 or 18, if you're seeing high-grade squamous intraepithelial lesion or findings, or glandular findings on any liquid-based cytology, or if there is persistence over a period of time. And that's exactly what that little rectangle box illustrates. If we could go to the next slide. I think I'll just be talking through now adenocarcinoma in situ. And again, right now we have a surveillance protocol for these patients, which is very wieldy. It is a lifelong commitment to annual co-tests, or annual co-tests indefinitely. I must say, in clinical practice, I'm not sure how well, rigorously or consistently this plays out over time. But essentially, adenocarcinoma is in situ is a precancerous HPV-associated lesion of the glandular cells lining the endocervical canal. And it is a known precursor to endocervical adenocarcinoma. These precursor lesions are actually identified usually at the time of excisional biopsy. And this may or may not have completely excised a lesion. So some attention, particularly by the specialist gynecologist or gynae-oncologist or colposcopist, will be around the margins, but you should be interested in that as well, and whether they're positive or negative. So there has been a welcome change, which actually on the next slide we will see takes away an indefinite or lifelong commitment to annual co-tests, provided the following circumstances occur. So we would start initially with annual co-testing for a period of 5 years. And if all those co-tests are negative, the interval between the co-tests can be expanded and extended to 3 years. That protocol then remains in place, 3 yearly co-tests, and if they remain negative for a period of 25 years, which is still a long time, then a person at that stage, if they are 70 years and under, can be returned to routine screening and would soon be exiting screening in that decade, or if in fact is older than 70, can exit from the National Cervical Screening Program and can do so safely. I'd now like to talk to immune deficiency. This has been a bit of a grey zone for us because a lot of the work that informs, or the categorisation or the inference around the frequency of screening in people who are immune deficient has really been drawn on work done with transplant recipients and people who have HIV. So it seems reasonable and has been acceptable for a long time now that they should be screened more frequently. And that's because they're deemed to have a substantially higher risk of conversion to cervical precancer and cancer. So if at any point during 3 yearly screening results show up any HPV, the recommendation currently is referral to an experienced colposcopist or a tertiary centre for further evaluation. So if we look on the next slide, this quite nicely shows us an expansion, I guess, of categories of people that we might see in our clinical practices, where we can be confident to request or understand that 3-yearly screening will apply. Deb, can I check with you? I mean, I do routinely write immune deficiency on my request form. I tend to make notes. I don't write why or what
You don't
category.
need to, actually. I think the key thing is, I mean, you can, but it's going to be easiest for the labs, I have to say, because they are going to just want to be able to follow the algorithm. So the main thing is, you know, you're the expert of, you know, your patient's immune deficiency. You know, the key thing is that this does keep changing all the time. I mean, this is an ever expanding field, but I think just on the path form, just writing immune deficiency is sufficient.
Is sufficient, exactly. Look, and when you're working with labs and you've got a good working relationship with them, if there's any question or concern, they will contact you, or equally, you can contact them and speak to them. Deb, I think that brings me to the all-exciting post-hysterectomy follow-up section. So
well, this is, I have to say, I've never seen so many questions about hysterectomy. You know? It's clearly the topic of the month. We'll go to the next slide, Joey, please. Thank you. So it is actually very exciting because it is much more simple. So we have simplified it to easy to understand annual testing, because basically it's either two consecutive tests, either co-tests following AIS, adenocarcinoma in situ, or HPV testing following squamous lesions treatment. Following squamous. I've probably got that mixed up. Co-test or HPV, depending on the cervical pathology and history. I'll leave it at that for now, until there's 2 negative tests on 2 consecutive occasions. I'll go to the next slide, please. So just on the left, this is what the flowchart used to look like. It was very difficult, I have to say. I just mangled up talking about that then. And I remember talking to Ranskog people about that chart when it had very first come out. And it was quite tricky. Whereas we've made it, what you can see here is we've made it really very straightforward. And I'll take you through it step by step. The key thing, just to remind us all, is, you know, don't make assumptions. If someone's had a hysterectomy, you do need to make sure that they've had a total hysterectomy. Sometimes that means looking or feeling. You know, I've been called out a few times. It happens rarely, but sometimes people, maybe if they've come from overseas, but also, you know, done here, may have had a partial hysterectomy, which means they've got a cervix and they still need ongoing cervical screening. A rather terrible thing happened in Ireland last year. Not to do with doctors or nurses, to do with systems, where the system to, you know, provide the advice about what to do next. The system made a mistake, and in fact they ended up not sending reminders to women who'd had a partial hysterectomy. They were all grouped together as hysterectomy, and in fact there were cervical cancers found, so it was a big public inquiry. So just remember that. But let's move on to the next slide now. So this is just, again, just looking at the new flow chart. What you're going to be doing is all based on screening history and the pathology findings at hysterectomy, which may or may not be known, but this is what it's based on. So understanding the screening history. So we'll just move on to the next slide and look at the different groups. So by far the most common group of people that you're going to see after a hysterectomy are those whose screening history has shown no evidence of high-grade changes or adenocarcinoma in situ. You know, they've got a benign history, a benign reason for their screening, for their hysterectomy rather, or they've had high-grade changes and test of cure has been completed after treatment. So for this group, as long as they've had no cervical pathology found at hysterectomy, so either low-grade changes, high-grade or AIS, then they don't need any further follow-up. So this is going to be the majority of your patients. You just need to get that history and then no further follow-up needed for this group. Now, we'll move on to the next group. So next slide, please. Excellent. So this is a group where they've either had high-grade changes, they've had a test of cure, it's been completed, and in fact, they've got then at the pathology, they either have LSIL or high-grade changes findings at hysterectomy. So that's just that group there. There's also the group, if we go to that, so they have annual HPV tests until HPV is not detected in 2 consecutive tests. So, and just a reminder that when we're talking about HPV tests, it always means, when we're talking about HPV tests, it means they have the HPV done. But of course, if it shows up any type of oncogenic HPV, 16 or 18 or non-16, 18, then then you need that other action. You need to get them back for cytology, or they're referred directly back for colposcopy. So just remember that that's the composite of the HPV test. So the next group, we'll just go over to the far right. So these are patients where they've had a history of high-grade change, but they've had a test of cure, but it's incomplete. So regardless of any pathology findings at hysterectomy, they are also able to have annual HPV tests until HPV is not detected in 2 consecutive test results. So that's important. Then the other group, you may have quite a few of these patients, it's where they've never been screened or they have an unknown screening history. And for this group, again, regardless of pathology findings at hysterectomy, then they can have the annual HPV test until they've had 2 consecutive negatives. Sometimes you do need to sort of dwell on these to sort of, get them into your brain, but hopefully it's more straightforward than before. We'll just come to the last section now. The next slide now, Jovi. Thank you. So this is for people where they've had the hysterectomy and in their screening history, they have had a history of adenocarcinoma in situ. So regardless of any pathology findings at hysterectomy, they don't go with the HPV test pathway because they've got this history of glandular AIS, and so they have annual co-tests until they've had 2 consecutive negative co-tests. And if you remember, a co-test is where the lab looks at HPV and the LBC at the same time, and if there's any abnormality in either of those, then that's not a negative test and they have to continue. So that's just important to be aware of. I hope that's much simpler than it was before. So I'm sure that might evoke a few questions. Lara, is there anything you'd like to add on to that?
No, Deb, I'm just keeping you company here.
That's great. Thank you.
No.
Excellent. So hopefully that's a lot easier. Sometimes you do have to sort of get your head around it, but it's certainly much simpler than it was before. And I think it's pretty easy to work out. So that's great. And we'll go to the next slide, please, Jovi. So this is what I mentioned before. This is this new, very practical recommendation. So it's the change in the guidelines, and this is to make it easier for us all, and including for our patients. And this is for people who've opted to have self-collection of their screening test. They've had that self-collected screening test. It's come back with HPV not 16-18 detected. You advise them to come back within 6 weeks or as early as possible to have the LBC to inform the risk category, but they don't come back. So they don't come back. You don't see them for ages. Maybe the next time they come in for something else, and you realise it's 9 months since they had the HPV. And so in this situation, you don't need to do an LBC. Too late for that, because in fact, if you remember rightly, in the intermediate risk pathway, what we're doing is we're then following them up 12 months later to see if that not 16-18 HPV is persistent. So in this situation, from any time from 9 months, if they return, they haven't had the LBC, then you actually offer HPV, and that of course can be self-collected HPV. So that's really handy. And again, obviously if it's negative, that means they can be discharged from the screening program. They've cleared that virus, so that's great news. If the HPV not 16-18 is persisting, then they do need that LBC, because you need to work out what the risk category is. So I think you'll all, again, just think about it in the context of your patients, but it certainly makes life easier for everyone, I think. So that's great. Okay, so we'll go to the next question. No, we've got you, Lara. You're going to talk about the really important things around unsatisfactory results.
Yep. Deb, did you want to talk to any of the questions post-hister now, or shall we get on?
I think we might stick to yes, let's do that.
I think so too. We've got some helpful cases. And then we'll try and address as many of those as we can in that allocated time. So look, I like simplicity, and when it comes to unsatisfactory results, I just remember the magic number 6 weeks. And the reason why I remember that magic number is if you get an unsatisfactory result with an HPV test, and these unsatisfactory results are really quite uncommon. For those of you who are a little bit older, like Deb and I, you'll remember the days of the Pap smears program where we were actually getting quite a lot of unsatisfactory false negatives, etc. So we have a much more accurate test. But we also have, and I think it's important that those of you that, we're working with our labs actually are doing their best to ensure samples are appropriate and also that they're taking into account a number of things. And I do want to highlight that there is a cellularity control, particularly to ensure that cells are present and hence the potential to detect DNA is present. There are and will be circumstances when a self-collect is not actually performed as you've carefully instructed or asked. And in fact, there is no cellular material present, and that's a pickup that the lab is able to do. The other is also the presence of contaminants, and certainly there are controls in place to rule out or rule in or understand if there are in fact any of the contaminants listed present. So again, if a HPV test is unsatisfactory, then it is absolutely fine to repeat that test as soon as practical and ideally within 6 weeks. On the other side, for liquid-based cytology, what is required and preferred is that you wait 6 weeks, and that's because you've actually sampled directly from the cervix and we need to allow some time for regeneration of cells. Next slide, please. So this is important as well. We have people here who are practicing across the country in various settings, and each of you will have your own relationship with laboratories, and they will support you in a variety of ways. There are really 2 options for the type of sample that you will be returning on behalf of your patient when it comes to self-collection. One is a 1-step process and the other is a 2-step process. Many of you will now be familiar with the red top flock swab, and that swab is validated for accuracy or precision and should be the only swab that you're using when you're supporting patients to take their own sample, and that swab can be directly returned to the laboratory. However, some laboratories have systems in place that require you to return a liquid-based sample, and what that actually means is that you, not the patient, will need to resuspend the sample from the red top flock swab into the thin prep vial. So that's a 2-step protocol, and I would encourage you to know and understand which one you're supported to do. And if you have a preference, I certainly do, for a 1-step, I'd suggest you advocate strongly to be supported to provide that service in that way. Now, what's really important is the lab has no way of telling when you send a thin prep vial in, whether that was clinician collected or self-collected, and that can actually have a ramification on reporting and the incidence of false negatives. So again, one thing I would ask you to do when you're doing the 2-step process and sending in the vial that has the resuspended self-collect sample in it, that you note on the lab form SC or self-collected. Deb, anything else you want to add there?
No, I think you've covered that very thorough. So
we'll move to the most exciting part of the talk, Deb, I think, which is now the interactive cases, and I'm going to hand over to you for those.
Fantastic. Thanks so much, Lara. And I just wanted to thank you all for your fantastic questions, by the way, and engagement. It's really great to get all these. So we'll make sure we can cover as many as we can. But let's just come to these cases. So we're going to meet 2 people. And we've got a series of questions which we're going to do some of those lovely polls for. So first of all, we're going to meet Amal. She's 30. She presents for contraception. And we check if she's up to date with cervical screening through the provider portal of the NCSR. And you found that her first screening test was actually 12 months ago. You have a chat with Amal and she said, oh, she didn't think she needed to have it because she'd had HPV screening. So it wasn't until she talked to a friend that she realised she needed screening, but she had. You find out too that her test showed HPV not 1618 detected on a self-collected sample, and your records show that she did not return for her LBC. You do ask her whether she's got any symptoms suggestive of cervical cancer, which she hasn't. So what do you advise? So we'll go to the next slide, please, Jovi. So this is our polling question 1. So just a reminder, she had her first screening test 12 months ago, not 1618 HPV detected. She didn't return at that point for the LBC. It's now obviously 12 months on. What do you advise? So we'll let you have a look at that. Is it an LBC only test to determine her risk category, a co-test, that's HPV and LBC test, an HPV test, which could be self-collected, to check if the virus is cleared, or none of the above. So we're going to give you time to complete that polling capacity on to be able to do that. That's great. Okay, fantastic. We've got the results. And look, yes, so almost 75% of you, 3/4, have got that correct answer. So just to go through it, well, we've just really talked about it, haven't we? So she was late coming back for that LBC, and she's reached that 9-month threshold where we say, look, you can have a repeat HPV test. It could be self-collected. It could be clinician collected, but the main thing is that, we just wanted to check if that virus is cleared. So thank you. That was great. And so now we're just going to show you the correct answer. So thank you very much. That's great. And let's have a think about what happens next with Amal. So Jovi, I'll get you just to bring in the next animation here. So yep, if we just, can we just go back to the previous one? Yep, Amal's test comes back as HPV not 16 detected. So that's another one. And what do you advise now? So let's go to the next slide. So this is polling question 2. So what's your advice in this situation? So again, she's got HPV not 1618, 12 months after the first one. Do you advise her to return in another 12 months for a second follow-up HPV test to see if the virus is cleared? Do you advise her to return for an LBC test within 6 weeks to determine her risk category? Do you refer her for colposcopy? She was more than 2 years overdue for her initial screening test, or none of the above. So we'll just give you a bit of time with that. Yeah, so now I do know that this is a tricky question. That's what I'm going to say. So because in fact, the right answer here, and it is tricky because we all need to remember the intermediate risk pathway. But Jovi, if we just go to the correct answer here now, and I'll explain why it's correct. So the correct answer is going to show up in red here, and it is that she is referred to colposcopy as she was more than 2 years overdue for her initial screening test. So I'm just going to go to the next slide to explain this in full, and it relates to someone's question that I've seen in the chat as well. So this is just a reminder. This is nothing new, by the way. This is already in the guidelines. This has been in the guidelines since for the last few years. So you're all familiar with this, but we do know that the intermediate pathway can sometimes be a bit complex. So the key thing is that, so if someone has a not 1618 result and they have low grade or possible low grade or negative cytology, that means they're intermediate risk. And for everyone in that situation, we follow them up in 12 months' time and do a repeat HPV test. Now, for most people, the majority, and I think the question in the chat was that what about for a healthy person, no issues. She has persistent HPV for 2 consecutive years. Do we wait for her to have a 3rd consecutive HPV non-1618 before referring her to colposcopy? And the answer is yes. So for the majority of the population, the majority of people coming into the screening program, if they have persistent HPV not 1618, again, at that second follow-up test, we know it's very safe for them to have surveillance for another year. And then they come back for that second follow-up test. And if that's still persistent non-1618 HPV, they get referred for colposcopy regardless of cytology. But there are a small group of people, and they're important people, where it's deemed that they are at higher risk of harbouring a high-grade abnormality even if they have negative cytology, but they still have persistent HPV 16, not 16, 18 at that first follow-up test. So in other words, 12 months after the index case. And who are these groups? Well, it does include Amal, because in fact, if you remember, her first screening test was actually, she was late. It was only 12 months ago. She's age 30 now, so she is under-screened. So she falls into that category of being overdue for screening by at least 2 years for her first screening test, and in fact, so she is directly referred to colposcopy, as are people who are age 50 years and above, and Aboriginal and Torres Strait Islander background people. So it's just remembering, most people, we can surveil them up to 3 years, but for this small group, we can't. So we have to just make sure that, that if they have a repeat follow-up test that of not 16, 18, they need referral. So let's move on there. So let's carry on with Amal. So she is referred for colposcopy, and the LBC is taken during this visit. So you don't need to get her to come back to you if she had that, self-collected test. The colposcopies and biopsies confirm high-grade lesions with SIM2, and she has a loop excision procedure, and she's referred back to you for test of cure 12 months after treatment. So which test do you advise Amal in terms of test of cure? So here's the polling test here. So we'll get that poll going. So what's a test of cure test following treatment for HSIL SIN2? So is it annual co-testing, HPV and LBC, on the same test at 2 consecutive negative tests? Is it an HPV test with a reflex liquid-based cytology, clinician collected from the cervix annually? So it can be clinician collected from the cervix annually until 2 consecutive negative tests. Is it an HPV test self-collected from the vagina annually until there's 2 consecutive negative tests? Or is it an LBC annually until there are 2 consecutive negative tests? Now, I will say it's a bit of a trick question. I'm going to tell you that in advance, because there may be more than one correct answer here. You've done very well, actually. It isn't, though. It isn't co-testing, because we've changed now from co-test to HPV test. So the test of cure now, after a high-grade lesion, the squamous lesion, SIN2 or SIN3, is actually 2 consecutive HPV tests. Now, those HPV tests could actually be either self-collected or clinician collected. So I think, you've done well with that. So Jovi, let's just close this down. It's not just an LBC test. It's the HPV test. Obviously, if it's clinician collected, then there will be reflex liquid-based cytology done on that test. If it's positive for oncogenic HPV, if it's a self-collected test, then that person needs to come back for the cytology to inform next steps. So that's good. So Amal completes the test of cure and she's discharged. It's all negative, and she's negative for HPV on those 2 consecutive occasions, and she's discharged to routine screening. Now let's move on and meet Frida. So this is Frida. She presents with her daughter for cervical screening. She's age 72. Her last screen was 10 years ago. She assumed she didn't need any more screening. She's not been sexually active since her husband died 8 years ago. She also remembers a very bad experience with her last pap smear. So she's very agreeable to the idea of self-collection, but the test comes back as unsatisfactory. And what you find, what the lab has said, is that there are, absent cells. So it does suggest, I don't like this term, actually, I must say, that some of our lab friends use to be socially unsatisfactory. So in other words, it looks like Frida actually, she was still nervous around cervical screening. She took the swab behind the curtain, or perhaps took it to the bathroom, but she actually didn't insert it into the vagina for a variety of reasons. We sometimes can't, guess what those are, but basically that's the result. So it's come back as unsatisfactory. So we do organise an appointment within 6 weeks. There's no need to wait, of course, to sensitively discuss the result with Frida. And you can advise her that, if she wants to, if she prefers, you could actually assist her with taking the self-collected vaginal sample. In fact, she's very agreeable to that, because she does remember that it was a bad experience last time, but she's just hesitant about doing this herself. She's not sure she's going to get it right. And don't underestimate assisted self-collection. We know that it can be really useful for helping people who are hesitant to take their own self-collected sample, but they really don't want to, they've made a choice, they don't want a speculum exam. So the test comes back with HPV NOX16/18 detected. So what do we advise next? So let's have a look at the options. So do we ask Frida to return for a follow-up HPV test in 12 months' time? Do we ask her to return for an LBC test, a cytology test within 6 weeks to determine the risk category? Do we advise that referral to colposcopy is recommended, or is it none of the above? And we'll give you just some time to answer these. Excellent, excellent. Well, we did mention this before. The key thing here, of course, is Frida's age that we mentioned, and it's this concept of exit testing that I mentioned before. And the majority of you are correct with this, that referral to colposcopy is recommended. So we'll just go to the next slide. Thank you, Jovi. So Frida is referred for colposcopy. So just a bit of a summary. Patients can be discharged from the program if they're 70 to 75 and have had a screening test at which HPV is not detected. But if any type of HPV is found, non-16, 18, 16, 18, then people are referred to colposcopy. If the sample was self-collected, there's no need to return for that LBC because it's going to be collected at that time. So we do advise Frida. We talked to her about the referral to colposcopy. She had that very uncomfortable pap smear. She's postmenopausal, and we do advise that she has a 2-week course of vaginal estrogen prior to the colposcopy. Generally, you exclude the 2 nights immediately before, so the cream doesn't get in the way. And the colposcopy shows adenocarcinoma in situ. It's confirmed with a diagnostic cone biopsy. She has complete excision with clear margins, and she returns to you for ongoing surveillance. So let's go to the next slide. So which test do you offer Frida for surveillance following treatment of AIS, adenocarcinoma in situ? So we'll start the poll. Do you offer an HPV test with reflex liquid-based cytology? Clinician collected from the cervix annually until she's had 2 consecutive negative tests. Do you offer an HPV test, self-collected from the vagina annually until there's 2 consecutive negative tests? Do you offer an LBC annually until 2 consecutive negative tests, or do you offer annual co-testing with HPV and LBC? Wonderful. So this one, again, it's a tricky question. The correct answer, most of you have got that correct answer right. I mean, these are brand new changes, of course. So it is actually after AIS, then always, if you remember back to the slide that Lara showed, it's annual co-testing. So that's HPV and LBC. Now we have changed it a little bit. It used to be for life. I mean, Frida is already 72, so we know that they can stop this annual co-testing after 25 years of co-tests. We know that they can change from annual to just go down in frequency of the co-testing after 5 years, but basically it is co-testing. So that's just important to remember. So that's a good reminder. So thank you. And on to the next slide, Jovi. And I'm going to hand over to, now, who am I handing this to? Is this to you, Lara, or Jovi?
It's to Lara.
Yeah.
Excellent.
Just before I go to this, Deb, I've worked out there are about 5 or 6 questions which I can knock off really quickly, and
excellent.
They all pertain to sampling and timing and samples. So audience, bear with me. Absolutely right, Mr. or Ms. Anonymous. The red top flock swab should be discarded after it's been agitated and releases the sample material into the liquid-based vial. So you're absolutely right there. Thank you for that comment. Megan, that's right. Some labs will forward on the flock swab to a laboratory such as VCS here in Melbourne when they themselves are not able to support that collection method. And there are some really helpful arrangements in place around the country. So again, your practice manager or practice nurse could look into how your practice can be supported in terms of what the clinicians and doctors there would like. Assisted, in inverted commas, self-collection. So when might this occur? And it's actually always been something which has been supported by the program. Range of scenarios, people with low vision, poor vision, significant Parkinsonian tremor, very tight hips due to an arthritic process, lack of confidence, preference. In those situations, if the patient has been given their options, prefers self-collection, but asks for the clinician to actually do the self-collection, that's absolutely fine. Deb, I think you're nodding. And
yes, absolutely fine.
Absolutely fine. You don't need to write anything on the form like assisted or I helped or doctor assisted. It's self-collection. So thanks for that question. There is absolutely no need to wait before referring to colposcopy. Often we're waiting too long to get people into colposcopy in a timely way. Now, when your test returns a 16/18 on a self-collected sample on a patient, you don't take the LBC. You actually organise a direct referral to colposcopy, and at that time, a liquid-based cytology test will be taken. So that addresses, I think, Kim White's question. We often would be asked about test of cure, and this harks back to the pap smear days as well. Will we accept a test of cure that's done before 9 months? Now, I know that patients have travel plans and they're busy and all sorts of things happen, and they may not be able to come in annually exactly at the 12 months, but you are doing them a disservice if you're not allowing them sufficient time for clearance of infection and for changes in the cervix to resolve. So we would strongly support, where possible, you encouraging your patients to come as close to that 12-month mark, and 9 months or before is too early. So I hope I've answered some questions. Jovi, do you want me to quickly speak to this? We're very happy for you to.
And I need to clarify a couple of points because I probably was a bit misleading in the last case.
Yep.
So,
and then we'll go to you, Deb, and then we're getting close to resources and Q&A. So look, we want to commend this to you. This is the self-collection for cervical screening mini audit. It was the brainchild of 2 specific interest groups, notably our environmental medicine, environmental health specific interest group, who really put some thought into really the green aspect of saving plastic specular across this nation. And it's a very simple, straightforward audit. It's not hard to do. It's not onerous, but it punches a nice 5 measuring outcomes and 1 reviewing performance. And it's been really endorsed by our membership, with 1,254 completing it last year in the CPD cycle. So we really encourage you to consider doing a self-collection mini audit as an audit activity for this year's CPD. Deb, I think I'm over to you now for resources, and you might want to make some commentary, as you said, regarding.
Yes, I'll just pick up a couple of questions, then we'll move on to the next slide. So I can see someone's asked about, yes, the register sends reminders 3 months before someone's due for their cervical screening test, and that's, you know, they can get the rebate on that, and that also happens in the 3 months before someone turns 25. So I think that answers that question. So if someone turns up 3 months shy of their 25th birthday, then they can have that screening test. In the Frida test, someone's saying, Julie, thank you, does she continue to have screening for the rest of her life? Yes, I have to say with AIS at the moment, we just don't have enough data to say that it's safe to stop those annual co-tests. They can go down in frequency. But for someone who hasn't had a hysterectomy, she's had the cone biopsy, the excisional treatment with an excisional cone biopsy, then no, she does need that annual screening. There was another one I was going to do quickly. Oh, I know, someone said around a hysterectomy, if the register keeps saying this person needs screening, she had a hysterectomy many years ago, but we don't know what the results of the hysterectomy pathology were. Look, one thing you could do is just follow that pathway where you could have the advice is for, if you didn't know someone's screening history, just have the 2 consecutive HPV tests. And if they're both negative, then that person doesn't need to go back for any further screening. But let's go on to the next slide now. I'm sure we're going to mop up all of these questions. So I won't dwell on these. We want to do all the questions, but this is just to highlight these really fabulous resources. These are all the links to them. They're all gathered together on the same website. They're easily accessed through the guidelines as well. So you've got the overall practice guidelines. I'd urge you all to have a look. What we're talking about here is they're available at the moment on the website. So I just looked them up this afternoon again. But they're not coming into effect until the 14th of April. And what that means is the laboratories, are still following the current advice, that's what we call it, but from the 14th of April 2025, not too long from now, then the laboratories will change all their recommendations in line with these new guidelines. So you can just this is for you to get used to these now, but from that time, this is the recommendations. So we've got this healthcare provider toolkit. I don't think many people know about it. It's really great. It's around, just again, particularly around bringing in under-screened people. So really great information, for instance, on providing screening for the LGBTQ community or people with disability, but also just handy tips as well. So there's just a lot of good information for you. There's a summary guide for health providers that Lara talked about, and there's a quick 2-page reference guide as well, which potentially you could print off and laminate. So lots of good resources. Next slide, please, Jovi. There's also, if you remember, there was previously some training modules when the program first came out, and there's some updated training modules now. They're all accredited for CPD points, of course, and they're available through the ACPCC website. So there's quite a few modules there. So I just urge you all to just have a look at that web link and see, how you can upskill yourself and, really become experts in this. So thank you. Next slide, Jovi. And I'd just like to finish by acknowledging just the support of the National Cervical Screening Program at the Department of Health and Aged Care, particularly the Director, Diane Krishtik, and Kelly Hughes, but also thank Marion Saville at the Australian Centre for the Prevention of Cervical Cancer and her team for the basis of many of these slides. So thank you to all. And Jovi, I think it's over to the Q&A now. So we've got lots of Qs. Yep. We've given quite a lot of A's.
Deb, I might, Deb, I'll give you an opportunity to just have a scan through. I'll pick up another 4 or 5 quickly. Sure. And then I'll hand over to you. Look, some really good questions here. The audit, Fatima, the mini audit is quite self-explanatory. What you'll actually do is you'll be given a table to fill out so that as you're actually offering the choice of self-collection and should it be taken up, there'll be a key prompts there of what you need to fill out as part of that consultation and what you might consider. It's really easy to do. It's I think it's 5 patients. It's not onerous. So hopefully that helps with that. Yes, there are absolutely lab standards, very rigorous standards around reporting and language and alignment to recommendations. If you feel that your lab has provided a recommendation that doesn't seem to either align to the guidelines or to your clinical understanding and interpretation of those, I would really encourage you to pick up the phone and have a conversation with the lab. I think that's a really good place to start. Screening in other countries, look, our society here in Australia is one of the most diverse. It's very important that we understand that screening here and in other places is not necessarily an equal match. We do know Australia has an exceptional screening program. Where possible, I do encourage patients to get involved in obtaining relevant past screening history information. Often they're best to contact previous doctors or specialists from where they came from. If I can't make sense of it, I actually then defer to, well, what would I do for someone with these individual characteristics clinically, age and stage in their life? How do they slot into our program here? And I would take it from there. So it's not an absolute answer. Nothing's perfect, but I think that's a reasonable approach. People often ask, what is the difference between a co-test and a HPV test and reflex liquid-based cytology? It's an excellent question. It was one we hoped we addressed well when we brought in HPV 5-yearly screening. I'll explain it right now. A co-test usually occurs not as a routine asymptomatic screening test. A co-test happens usually when there's a clinical indicator and you're in a follow-up arm. When we first offer screening, as in the CST or cervical screening, and indeed if it is clinician collected, it should be to those individuals who are eligible, who are at baseline risk. We're talking asymptomatic routine. In that circumstance, if the patient says, yep, I'm happy to have a clinician collected sample, the sample will be sent to the lab in a liquid-based vial. The first thing the lab will do is an HPV test. Based on that result, the lab will then run reflex liquid-based cytology. So it's sequential and two-step. A co-test means that the HPV test and the liquid-based cytology will be run at the same time. The liquid-based cytology will not be based on the result of the HPV. Older women, very quickly, Deb, and then over to you. Older women presenting with HPV 18 who had no HPV detected 5 years ago. You did qualify in your comment that there's been no new sexual partner or sexual activity. Look, the HPV test is pretty accurate. We do have a fairly ageist society. Increasingly now, women and men, particularly living longer and are sexually active and are changing partners more so into those older years. I don't know if that's particularly helpful, but I would maintain an open mind. However, as clinicians, it's not our role, I guess, to infer or draw conclusions beyond what we can with the facts before us. And I know sometimes our patients are seeking more information and guidance. It's a tricky area. And I think the thing we need to focus on is HPV 18 is a signal for colposcopic evaluation and timely at that. Thanks, Deb. Over to you.
Thank you. Yes, no, that's an interesting question, Karen. I mean, often, I'll just give the possibilities that, just with age, we know that decline in immunity can mean that, HPV that's been around for a very long time then becomes detectable. So, but it's giving those options and not making assumptions and let people work it out. I have to say I was busy writing down questions, so I hope I'm not going to repeat ones you've talked to, Lara. So just tell me if I have. Someone has talked about the person with persistent 16 HPV 16, where there's normal colposcopy. I did just want to say with this that we've got some new data out of a country where they weren't really following these people up. And what we do know is that HPV 16 in particular, more than 18, is a unique, very powerful carcinogen. So even where people have, negative colposcopies, we still have to be alert to these 16s. And so really it is, from our perspective in primary care, unfortunately, we do have to keep referring these people to the gynecologists, and we're opening up new guidance around what we call endocervical curettage, for instance, where we're looking up in the canal just to make sure there's not something going on there. So we just can't leave these group alone and say, oh, they've got normal colposcopies, nothing's going on, let's see them again in 10 years' time. So we really do have to just ensure that we are following these people up and that they are seeing the gynecologist for thorough review. Someone talked about international comparisons. So what if someone's had screening overseas, and they come and they start screening here and we don't have any history on them? I think the key thing is, it's very hard. There's lots of different screening programs in different countries. We can't keep on top of them all. Basically, someone who's newly arrived in the country would be provided with, and they've got a Medicare card, they'll be provided with a screening test because they'll be perceived as being a new screener. Obviously, it's up to you then to be able to get as much of a history as you can to help inform what's happening. But yes, we don't have those sort of comparisons, I suppose, but it's just you doing your best to get the best history you can. Someone says, you know, someone comes in and they're just at the start of their menstrual period, is it best to offer, you know, self-collection or to get them to come back? That'll entirely depend on your judgment. Just to say that the rate of unsatisfactory tests due to you know, contamination with blood is actually quite low. You have to have a lot of bleeding, but sometimes they are, you know, they do come back as unsatisfactory, as Lara has talked about. But I think it's you weighing up whether you think, you know, if you know someone so well that they're going to, you know, they're going to come back, then that's fine. But generally, you know, you'd be inclined, they've come all the way, they've come to see you. I'd be inclined generally to offer the self-collection. That may well come back, you know, completely fine, of course. So that's just your judgment. There is sexual abuse. How do we tackle that with a young, shy woman? You know, I think the key thing is that we're not, you know, we're not wanting to elicit disclosures necessarily. I think the key thing would be to just talking in the third person around, you know, who we offer screening to, who needs screening. It's anyone who's ever had any sort of sexual contact, and that just, you know, saying that can sometimes be, you know, be non-consensual, and you know, we know we've got a, you know, we really do offer cervical screening to everyone. It's a very simple test to do. So you're just putting that in that person's court really to decide whether they want to have that test. And really most people will be very accepting, particularly now we've got that self-collection option. I think another person asked about home testing. Is it going to be like sending kits home, you know, a bit like for colorectal cancer? So I've got the name on there. So I think, you know, the key thing is absolutely we are looking now at new models. The key thing now is to bring in under-screened people into the program. But our screening program is very much embedded within primary care. And we know there's very good reasons for that, because you've got that, you know, continuity of care. If I'm giving someone you know, a swab in the clinic to do self-collection and I get it back, I know I've got it back. Whereas if it goes home, we know there's a lower chance that it, you know, or a higher chance rather, it may not come back. But we are investigating lots of new models of care to ensure that we can bring people in, but it's about having those safeguards in place. And again, just having the GP, you play such an important role at the centre of those things. But some of you, of course, may be having some telehealth models where you've got that, you know, that well-established quality assurance in place to ensure that, you know, the key thing, of course, is first of all, you know, to make sure the person has that test and, you know, doesn't lose the swab, for instance. But the other key thing, of course, is that it gets to the lab, and then when the results come out,
there was a question around a list of biological actives, and Karen, I'm not aware of such a list, and I think what we need to do as GPs is apply some sound judgment around both the severity of any long-standing chronic immune challenging disease process we were aware of our patients had, and also understood both the frequency, consistency with which they were receiving immune modulating treatment, whatever it would be. And in the end, I'm sure that none of us are really going to be abusing the system, and I would encourage you to be confident to put immune deficiency on the request form. Deb, I'll answer two more and then come.
I'm sorry about that. That was the wonderful Sydney Uni internet dropping out.
Not at all. Not at all. I guess just to support Deb's excellent advice around the shy young 25-year-old or young person. And I think also we've got a really good question about 25 and not sexually active. So I know, Deb, I do, and you will have had many of these conversations. Yeah. I tend to start with a generic in Australia currently, what we offer all sexually active Australians, and particularly those with the cervix or women, the opportunity to start screening from the age of 25. It's important to understand that we're looking to screen to detect early infection with a virus known as HPV or human papillomavirus. Many young Australians have been vaccinated, and so you may have heard about this virus. Well, it can be and is linked to serious change in the cervix down the track. People ask, how long can it be dormant? It can be dormant or present for decades. and usually it takes many, many years to move from abnormal low-grade change to significant change. We often work in decades. That's, sorry, an aside and an answer to that question. But back to the conversation with young people, I think it's important to explain that, that HPV is transmitted through sexual activity. And then you might say something along the lines, I'd like to describe the sorts of HPV activity that we know can be linked to transmission, because for people, a definition of being a virgin or not sexually active may mean oral sex is on and genital skin-to-skin contact is on, but penetrative sex defines sexual activity, and no, I'm not sexually active. And so it really helps both provide useful information in the consultation and clarification using very simple terms. With the shy young 25-year-old and a suspected or possible history of abuse, I would be establishing a rapport. And it might not be the first or second consultation until I'm in a position where I think trust is established and the patient is feeling comfortable that I would explore this further. And that's just to add on from the excellent advice Deb has given. The PHN question is an excellent one, and we welcome that question. And Deb, you may wish to speak to it too. But look, there are some excellent resources and speakers available currently. And I would just encourage any PHN to get on board, whether it be through ACPCC, through Deb, through the college here. Obviously, these webinars are recorded, and we're doing this again on the 13th of March, which is timely for an April start. Which brings me to, well, what if someone's in a pathway and the recommendation changes? And at the moment, we're in a lovely hiatus period where you don't need to flip people across to a new recommendation. You can just allow them to continue where they are. Equally, if you wanted to start offering, I believe, the HPV self-collect for the 9 months and later, it would be reasonable. Deb, your thoughts around that?
No, I think that would be reasonable. The other case that may well come up is that you're halfway through a test of cure. So in other words, you've done a co-test and they're due for their next annual co-test, but now it's an HPV test after treatment for a high-grade change. Then you would just do the HPV test. And if there's two, you know, obviously the first HPV would have been negative with low-grade changes or negative changes, no cytology changes. And if you've got a second consecutive negative HPV, then that would be a completed test of cure. So that's useful. But yes, I mean, they do come into effect. But I think, you know, if you're taking up some of these changes, certainly your patient shouldn't be disadvantaged by those. Someone says, I'm curious about HPV 68, any specific guidelines? So that's one of the non-16/18 types. So at the moment, as you know, and this will stay for some time, but I'll talk to you about what may happen in the future, is that, you know, it's part of the whole group of those non-16/18 types. So there's no specific advice. It just follows that advice for the intermediate risk pathway. In the future, we may, so what happens at the moment is that we test someone, they've got not 16/18 type HPV. We test them again in a year. They still have it. It may be a different type of those, one of those different non-16/18 types. We don't know that at the moment. So it may be that we're over following people up where they don't, you know, they've got a new infection which is transient. It's not going to cause any challenges. So in the future, we may move to something called extended genotyping, where we can actually see whether it's the same type, but we're not doing that yet. So that's just one thing there. So Claire Holberton, that's nice. You're asking me to talk about the work with screening with people with disabilities. We know that this group's very underscreened. We had an excellent campaign last year called Screen Me to raise awareness of screening for people with disabilities. We know there's lots of barriers, lots of, unfortunately, you know, history of past sexual abuse and trauma, which can be real challenges. I would say that the offer of assisted self-collection is really useful in this situation. We're doing in our research to look at, you know, how useful it is. We've got lots of resources now. There's some resources at the moment on the NCSP website under the Screen Me site. So I'd urge you all to look those up. But certainly we're also looking, there's some research going on around, you know,
And
community
Deb,
health
just-
nurses going to group homes. That's it.
Just to jump in there, and I know Jovi will want us to wrap up, but on that
Oh, yes, sorry.
important question,
Yes.
last year we did run a series of optimising cervical screening in people living with disability webinars.
Right.
Those recordings are available and
They are.
accessible. And of course, Deb, we had a fantastic advocate and woman who lives with disability, really giving us the perspective of the sorts of ways we could adapt, improve and change our practices and approach to be facilitative and supportive. And I know that Deb, that was really well received by our...
Yes, and thank you to Amanda O'Donovan, who's put some really great examples of yes, so fantastic, excellent. Lara, did you cover that the case around the you know, you could have an unidentified self-collected sample accidentally reflexed and reported as a false negative? Did you cover that one? You probably did.
Yes, I think I mentioned that when I was going through
fantastic.
that.
Yeah, there's a quality control in place.
Yes, that's exactly right. So I think we might have to hand over to Jovi, but do what we usually do, which was try and find response, try and put together some responses to those we haven't answered. Yep. We will possibly, Jovi, have an opportunity in March to take up some of these as well.
Yes, correct. So the next repeat webinar is on the 13th of March. So in the resource I'll be sending, I'll put the link to the next webinar.
Fantastic.
Thank you. So thank you. So I'd like to extend my thanks to Lara and Deb and everyone that's joined us online tonight. We hope you enjoyed the session. So again, just a reminder, a copy of tonight's presentation along with resources and the link to the recording of the session will be sent to your registered email address within the next week. And I guess that's all that we have time for this evening. And we'll see you again if you'd like to join us on the 13th of March. So thank you and good night.
Thanks, everyone.